This is a PowerPoint review of Chapter 232, General Approaches and Considerations for Pediatric Brain Tumors. This chapter and presentation are meant to provide an overview of the current understanding and approaches to the care of pediatric brain tumor patients. It is primarily geared for providers outside the neurosurgical field to act as a resource and provide a framework and guidance regarding the recognition, diagnosis, and treatment of pediatric brain tumors. Pediatric brain tumors are the most common solid tumors in childhood, accounting for up to 1/3 of all childhood cancer diagnoses, and are also the leading cause of cancer-related deaths in children. According to the Central Brain Tumor Registry of the U.S., the annual incidence is nearly 6 per 100,000 children, age 0 to 19 years old, with a predilection for the children aged 0 to 4 and 15 to 19 over those in between. As with many facets of medicine, it is important to remember that children are not just little adults, and this is true of pediatric brain tumor diagnoses as well. Central nervous system malignancies in childhood differ vastly from those seen in adulthood, in both histology and location, and the differences have significant implications for their diagnosis, treatment, and prognoses. In contrast to CNS tumors in adults, most of which are located supratentorially, approximately 1/2 of all childhood CNS tumors are infratentorial. The represented schematic shows the differences in adult versus pediatric astrocytomas in terms of their grade, with pediatric patients having much lower grades, their location, with pediatric astrocytomas occurring most often in the brainstem, cerebellum, and optic pathway, as opposed to in adults, the cortex or the thalamus, as well as the difference at the time of diagnosis in their age. Classification schemes for CNS tumors are based on the cell type from which the tumor originated, although subclassifications exist based on histologic or cytologic criteria. According to the most recent report by the Central Brain Tumor Registry, the most common tumors in children 0 to 14 years of age include gliomas, of which the majority are low-grade or pilocytic astrocytomas. These account for up to 25% of all pediatric brain tumors. Pilocytic astrocytomas can occur in various locations and include the brainstem, cerebellum, hypothalamus, or optic pathway, and each of these locations differs in their treatment or management. Medulloblastomas, a type of embryonal tumor, follow behind, accounting for 15 to 20%. With neuronal tumors and mixed neuronal glial tumors, as well as ependymomas following still. Less likely, but still seen within pediatric brain tumors, include germ cell tumors, atypical teratoid rhabdoid tumors, or craniopharyngiomas. It is clear that early diagnosis and treatment are paramount to improving the chance for long-term cure. Identifying a concern for a pediatric brain tumor, however, can prove to be a challenge for primary providers, mainly because the symptoms of childhood brain tumors can be nonspecific and are often seen in many common non-life-threatening diagnoses. Consequently, pediatricians need to be able to identify the dangerously sick child from the child with the self-limiting childhood illness. Signs and symptoms of brain tumors are generally a consequence of tumor location, the patient's age, and histology. Infratentorial tumors typically present with signs of raised intracranial pressure from the associated hydrocephalus created by the obstruction of CSF flow and the tumor location. This includes headaches, nausea, vomiting, and lethargy. Early morning symptoms that improve or resolve during the day are particularly concerning for a CNS pathology and are typically considered a red flag sign. Signs of raised intracranial pressure in younger patients can include a bulging fontanelle or progressive macrocephaly, as well as eye movement abnormalities, including limited upgaze. Supratentorial tumors tend to present with more focal deficits due to the mass effect or irritation to the surrounding tissue. This often causes hemiplegia, speech challenges, sensory deficits, visual concerns, or even seizure activity. Cranial imaging is imperative in making the diagnosis of a pediatric brain tumor. Because computed tomography imaging is typically easily accessible, fast, and does not require anesthesia to obtain, it is often the first imaging modality obtained in the evaluation. CT is able to identify large abnormalities, or the sequela of tumors in certain locations, such as hydrocephalus, but may miss small lesions or leptomeningeal metastatic disease. Additionally, it provides limited information for surgical planning. Magnetic resonance imaging is the gold standard imaging study for the optimal evaluation of pediatric brain tumors. If a central nervous system tumor in a pediatric patient is identified, imaging should be extended to include the entire spine, secondary to the propensity for many of the malignant pediatric tumors to metastasize. PET scanning and spectroscopy imaging play a less valuable role in the assessment of pediatric brain tumors compared to other neoplastic workups. In addition to imaging, ancillary testing may also be helpful. This can include the attainment of cerebrospinal fluid to assess for disseminated disease, and is particularly helpful in potentially malignant tumors such as medulloblastomas and ependymomas. Serum protein or CSF markers may also be helpful in the assessment of germ cell tumors. Therapy assessments, including speech, physical, and occupational therapy evaluations, can be helpful in understanding the extent of baseline neurologic deficits, as well as help guide dietary plans for safe swallowing. Lastly, ophthalmology evaluations to assess for eye movement abnormalities or for papilledema extent in the setting of raised intracranial pressure become valuable tools for follow-up assessments. Proper treatment planning requires the thoughtful, multidisciplinary approach of harnessing the expertise of many different providers, including neurosurgery, oncology, radiology, and radiation oncology, with the purpose of devising the best individualized treatment plan for each specific patient. There are, however, clinical situations that may arise that warrant immediate or urgent intervention to preserve neurologic function and prevent death. Patients should initially be assessed for any signs of symptomatic or severe elevations in intracranial pressure. If there are clinical indications of such, immediate intervention should be considered. This may require the postponement of additional imaging if the full assessment has not been completed. However, it is imperative to ensure the patient is safe to undergo further imaging, both in the recumbent position and many times under general anesthesia at this age, without risk of detrimental effects to their health and neurologic status. If symptomatic hydrocephalus is present, as depicted in the first two images, consideration should be given to emergent CSF diversion, with placement of an external ventricular drain. Limitations on the amount of CSF drainage is imperative and should be strictly abided by to prevent upward herniation. If significant vasogenic edema and mass effect is noted, treatment with dexamethasone can often prevent progressive symptoms and may even alleviate current symptomatology. Lastly, if significant and life-threatening hemorrhage is noted, as evident in the last picture, and either within the tumor or causing obstructive concerns, consideration of emergent CSF diversion or decompressive procedures as life-saving measures should be entertained. Plans to return to the operating room for formal terminal management can be completed when all the necessary information has been obtained and the treatment plan has been devised. Due to the diversity in histologies and locations, there is no specific protocol for treatment that encompasses the management of pediatric brain tumors. And in all actuality, management is very diverse and far outside the scope of this general chapter. Additionally, although the treatment of pediatric brain tumors is becoming more sophisticated and personalized, the mainstay of treatment includes surgery, chemotherapy, and radiation therapy. Notation should be made that observation with close follow-up imaging is also an option and often utilized in apparent low-grade lesions that have the potential to remain stable, a scenario that is becoming more commonly identified with the utilization and availability of MR imaging. If treatment is necessary, the best prognosis for most CNS tumors is in the setting of a gross total resection, and this should be attempted if safe and feasible. In situations where gross total resection is not possible, consideration of debulking the tumor to reduce tumor burden should be considered, or at minimum tissue diagnosis by biopsy to guide adjuvant therapy should be entertained. Depending on the tumor type, response rates to chemotherapy and radiation differ, and a multidisciplinary and well-versed team in the management of pediatric brain tumors is essential in identifying the best treatment plan. Notation should be made of the newer treatment platforms that are available, and will likely be more readily a part of treatment planning protocols as research into these agents progresses and includes immunotherapy as well as molecular therapies. The end of therapy can bring many emotions for patients and their family, extending from fear to joy. Treatment is typically ceased in 3 scenarios, including cure, the recognition of stable disease, or progressive tumor burden despite the utilization of maximal treatment options. If tumor burden is progressive despite maximal treatment, consideration of transition to hospice should be discussed with the patient and their family. Even in the setting of cure or stable disease, ongoing reassessment by the multidisciplinary team should continue. This not only continues with repeat imaging to ensure the disease burden is stable and does not recur, but also from the perspective of the complications from treatment, including the endocrinopathies and cognitive disabilities that can provide lifelong challenges for these patients after treatment. In addition, treatment can put patients at risk for the development of secondary malignancies, and despite stable imaging for an extended period of time, ongoing reassessment should be done for the development of these abnormalities in a delayed fashion.